The early signs of pancreatic cancer are very difficult. Reflux and dyspepsia is one of the most common signs. Some of the real critical signs that we look for, though, are what we call acute diabetes.
Welcome to Living Real Change, a podcast from Piedmont Healthcare. I'm your host, Dr. Lacey Knight, Chief Health Information Officer here at Piedmont. Join us as we highlight the people, the stories, and ideas that are transforming care and strengthening communities across Georgia. From inspiring patient journeys to expert health advice, each episode offers insight, hope, and a closer look at what real change looks like in healthcare today. Most of us don't think much about the pancreas until something goes wrong. But this small hidden organ plays a big role in keeping us alive and healthy. In today's episode, we sit down with Dr. Andrew Page, a surgical oncologist at Piedmont Healthcare, to talk about what makes the pancreas so important, why pancreatic cancer can be so hard to catch early, and how new breakthroughs are bringing hope to patients and families. Dr. Page shares what warning signs to look for, what's driving the rise in pancreatic cancer across the Southeast, and how Piedmont's early detection clinic is working to change outcomes, one patient at a time. So we have a lot to talk about with the pancreas and pancreatic cancer. I figured the first question is, what is the pancreas?
So, the pancreas has many responsibilities. A lot of people, like myself, that are pancreas enthusiasts like to call it the brain of the abdomen. It has two primary purposes. The first one is exocrine function, helps with digestion, helps as the food is passing from the stomach into the duodenum and distally from there. It helps figure out the acid base and the other types of enzymes to help break down food. That's the exocrine component. And then there's the endocrine component. And that's especially where it acts like a brain in that it helps regulate many of the hormones in the entire body. People tend to think of the pancreas a lot of times when it comes to diabetes. That's just one example, but the pancreas has the endocrine functions where it helps you regulate blood sugars and many other types of hormones.
Thank you for that. What ends up being the earliest signs of pancreatic cancer?
Yeah, you've hit the nail on the head there. So the early signs of pancreatic cancer really don't exist. People have tried to look at this and retrospectively, looking at people who've been diagnosed and looking backwards, trying to find screening tests for pancreatic cancer. The signs and symptoms are very difficult. The most common is what's called dyspepsia or reflux. Just got some vague abdominal complaints. And a lot of patients end up seeing, their physician, their GI, their surgeon, whoever, and they say, it's probably nothing. We'll put you on a medication, a PPI, for example, that'll help treat it. And most of the time that's the case. But reflux and dyspepsia is one of the most common signs. Some of the real critical signs that we look for, though, are what we call acute diabetes. You've got a pretty healthy patient who has come in with a little bit of weight loss. Their A1C has gone up a little bit, and their blood sugars are just poorly managed despite them being pretty healthy otherwise. And that is probably one of our most reliable, if you can call it that, signs and symptoms for the development of pancreatic cancer is dysregulation of that endocrine and sometimes that exocrine axis of, you've got greasy stools, you're losing weight, you're wasting protein somewhere. So those are the most common signs. Fortunately, or unfortunately rather, only 20% of patients present with symptoms that can get them to a curative intent surgery. So that's a loaded statement. What does that mean? So 20%, so 80%. So if I'm down in my clinic today in Noonan, and if I were to have 10 patients walk in through the door, 8 of them, if they were diagnosed with pancreatic cancer, are going to either have locally advanced, meaning I can't remove the tumor with surgery, or metastatic disease, meaning that surgery will never be part of their treatment algorithm. So only 20% of those patients diagnosed with pancreatic cancer even get to meet with a surgeon, which is just a pretty frightening number. So I appreciate the question about signs and symptoms that we should be looking for, because the ones that are fortunate to present with what we call painless jaundice, where their bile duct gets obstructed by the cancer. It's in a very strategic, specific spot that blocks up the bile duct. Those are the ones that fortunately we get to offer curative intent therapy to, but only that's only a small minority.
Okay. So you said, I think I heard you say kind of a vague abdominal discomfort, um, greasy stools, and then kind of changes in blood sugar management. These sounds like things that you really would have a lot of trouble picking up unless you're somehow regularly engaged with the healthcare system, doing routine testing and looking for things that are
Yes.
changing. Is that accurate?
Yeah, and it's 100% accurate. What we have recognized is that the relationship that our practice has with primary cares, and actually in the emergency room as well, has been really critical in helping us identify some of these patients that may be at higher risk. So, for example, if you come in, if you have a patient that comes in with elevated A1C. They're pretty healthy otherwise, but they have a smoking history. They've had a couple family relatives that have had pancreatic cancer. That elevation of suspicion needs to go up for both, those first line care clinicians. And we've seen that dial move a little bit. So we're excited about that because at Piedmont we know that there's a big footprint for the state, and reaching those primary care and first line clinicians is really critical, and identifying those patients that are at higher risk because there's a genetic component as well, which I hope we can talk about. But there's also a concern demographically in the United States that more patients, number one, the incidence is going up across the country. It's going up higher in the Southeast. People have looked at Mississippi, Louisiana, and Georgia. It's going up higher in all three of those states, disproportionately higher than across the country. And the patients are being diagnosed at younger ages. And that's a problem. I mean, you got this not very common cancer that's slowly increasing in incidence. It's increasing in younger patients, and especially in the Southeast, it's kind of starting to bubble up, and people are starting to recognize that this cancer is a big problem.
So before we get into the kind of risk factors and things like that, maybe you could just talk through the typical scenario of the diagnosis or what the process looks like for people that you can pick whether or not there's an example that is a bit more obscure, like some of the other stuff that you were mentioning, the belly pain and the greasy stools and endocrine dysfunction, or you can pick the obstructed painless jaundice example. But what does that look like when someone's got symptoms and they're ending up kind of going through the path to figure out if this is pancreatic cancer and confirming that it is?
Yeah, great question. So certainly, I don't want you to think that someone will pick the most common example of called painless jaundice. Someone that every patient that's starting to turn yellow has pancreatic cancer. In my world, I think everybody that's starting to turn yellow has pancreatic cancer. But for my clinic and our team's clinic, if someone were to, let's say, the classic example of the textbook patient would be they come to the emergency room because they went to their primary care, they were starting to turn yellow. You say, I just hadn't been feeling myself for the last few weeks, haven't been had a good appetite. They went to their primary care. The primary care sent off some labs, and their bilirubin was 10, so 10 times normal. And the emergency room gets them in. Confirm that they're yellow. Usually, the first thing is they'll complete the labs, confirm the jaundice. The rest of the labs are okay. They'll get a scan, and it'll show the classic double duct sign. That means that the bile duct and the pancreatic duct are both dilated, and it's usually because of an obstruction in the biliary and pancreatic systems, which has caused both the ducts to dilate up. In our world, that's textbook for pancreatic cancer 1, 2, and 3. And most of the time at Piedmont, which I'm really proud of how our team approach to how this has evolved, is we'll admit those patients, get them decompressed, usually with an ERCP, and get a biopsy at the same time, which leads to the mantra we have in our clinic, which is in most cancer surgery clinics is what is it? We got to figure out what it is. Second question is what stage is it? We can usually stage that with a good CT pancreas. And the third question is what's the plan? And that's where we work with whether we're going to give chemotherapy first or if we're going to do surgery first. Or if it's unfortunately metastatic, look at other alternative therapies outside of surgery.
What is an ERCP?
Yeah, an ERCP is an endoscopic retrograde pancreaticogram. And what that does is it looks at the biliary system and the pancreas, and it opens up the tubes and it looks for those in those ducts for abnormalities like masses, growths. You can do biopsies. A lot of the time we do them for stones. You can get bile duct stones and pancreatic duct stones. But it's an incredibly valuable tool for our program.
Let's maybe talk about the some of the risk factors, what that looks like, and then I'd love to hear about kind of your thought or vision for the early screening.
Absolutely. So first, risk factors for pancreatic cancer. So the first thing that I think is critical and that our team and Piedmont are really starting to get more strongly behind is the genetic component. So you can't leave genetics out of this. We know that about 10 to 15% of pancreatic cancers have a known genetic component. It's probably much higher, but we just don't know that number yet. I think it's probably 30 or 40%. So that's the first thing is the genetic component. Second are what we'd call, the modifiable risk factors. But the modifiable risk factors for pancreatic cancer are obesity, diabetes, alcohol, and smoking. And, that's part of the reason why people ask me, why is pancreatic cancer increasing in the Southeast so much? And that's probably why is the lifestyle modifications that a lot of us in the Southeast haven't taken on.
At Piedmont, quality care changes lives. Meet Tom, a lifelong medic who suddenly suffered a stroke at home. Tom was diagnosed, treated, and in surgery within minutes, thanks to seamless coordination across the entire care team.
I've seen firsthand how every second counts. When I needed help, Piedmont moved with speed and precision, and that saved my life. A week later, I was back at home with my family, back to work and back to living.
Hear more at piedmont.org/quality care. Piedmont, real change lives here.
So tell me about your screening approach or the outpatient screening clinic. What is that? What are you trying to accomplish?
The early detection clinic we've been working on it for a few years, and there are very clear guidelines for our patients that are at high risk. So we put them through these algorithms, and sometimes these algorithms change. So we have to be able to adapt and evolve as we start to understand the algorithms. But the thing I think excites most people about this early detection clinic is the opportunity to participate in research. This clinic is a place where we're already starting to develop early detection blood assays and some imaging tests to help us diagnose to be used as a screening test for pancreatic cancer. The imaging, we're coming along, but the screening tests, we've based on some really generous giving from many, many donors. We're able to participate with some of the best institutions in the world as part of multi-institutional collaborations to develop a blood screening test for pancreatic cancer for those patients who have family histories of cancer or that don't. So it's a really exciting time to be in that space.
That's really interesting. So just want to dive into that a little bit more. In terms of screening, what you're looking for, is this screening for really the genetic risk factors, or is there some other type of precursor, or component in the bloodstream that comes before the cancer develops?
Yeah, great question. No one really knows the answer so when we talk about colon cancer, the pathogenesis of a polyp to a cancer is pretty well established. In pancreatic cancer, it's a little different in that people think that, or researchers think that there might be actually separate processes of going from normal pancreas to cancer. Some people are maybe normal pancreas to precancerous neoplastic cyst to cancer to normal pancreas to boom, you've got cancer. And actually, younger patients are shown to have a less aggressive biology to their pancreatic cancer, and no one is really able to understand that yet. They think it may have to do with the immunogenicity of it, but what I think you're asking is what space can we get in to identify what even test to look for patients that could be developing pancreatic cancer. So pancreatic cysts, very hot because we've got these great tests, MRIs that are picking up pancreatic cysts left and right, and we don't know how aggressive to be with some of these. So that is actually what I call a sub goal of the early detection clinic on which patients need to get EUSs, and those are called endoscopic ultrasounds and biopsies, looking at the genetics of those cysts, which can vary from being completely benign to being very aggressive. But that also leads to the second question was, well, if I've got a cyst that's not supposed to be there, why don't you take it out? The problem is pancreatic surgery isn't something you just want to line people up and like be a high throughput, you know, or a surgical center for every cyst that comes through the door, which people did for a while. But fortunately, we don't do that anymore.
So I'm thinking about really kind of two categories. Maybe they're the same, maybe they're different, but there's a cohort for people that have been established with or diagnosed with the pancreatic cancer either through the ultrasound guided biopsy or something else. What's kind of the typical treatment approach for that? What types of roles are involved? I know we've touched on the GI doctor and the surgical oncologist as well as medical oncologist. I don't know if there's other types of roles, but what's the typical kind of treatment considerations for someone with a new diagnosis?
So first, we decompress them. We've got to fix their biliary tract. Well, as I explained it to patients, is we've got to fix the plumbing before we start down the oncology path. We fix the plumbing, we get a stent, then we get a biopsy. That biopsy is critical. When I was in training, and when I started at Piedmont 10 plus years ago, if you came in with a double duck sign, you just went straight to the OR. We've learned that algorithm works for some patients, but it's probably not the best algorithm for most patients. And why is that important? What do I mean by that? The best way to get to the best outcome with pancreatic cancer is to use every tool in the toolbox, from chemo to genetics to sometimes immunotherapy to trials. And so you get that biopsy, you now know that number one, it's probably pancreatic cancer. You can get your mutational analysis and genetic analysis and next gen sequencing testing on that tumor to help guide your next steps. Let's say this patient, this 65-year-old, has no targetable mutations and they're the standard bread and butter pancreatic cancer. And there's what we would recommend at Piedmont is we would give upfront chemotherapy. And I think most of the oncologists in the country would do that. And you give them that biologic stress test to push them to, number one, treat the tumor. Potentially, some people would say to downsize it. But most importantly, treat the micrometastatic disease that we know the majority of pancreatic cancer patients have. So that chemo treats the tumor and the spots outside of the cancer, the obvious cancer that we can see, which not a lot of patients are excited about because they want the tumor out.
Mhm.
And I get that. I've been there with my family. I understand that. But what we learned, unfortunately, is that 50% of the patients that went straight to the OR didn't get the chemo that they needed because they were still getting over their surgery. And then unfortunately, there was a small percentage, and I've had them myself, where you take them straight to the OR and they didn't get the chemo, and you're seeing them in their first post-op visit, and they've already got a high burden of metastatic disease. And that basically, I've put that unfortunate patient through a big surgery that they didn't need, and I've hurt their quality and quantity of life. So we recommend for most patients, again, the appropriate surgical patients that don't have a targetable mutation or a genetic signal that we can target, to get upfront chemotherapy and then hopefully get them to surgery after 4 to 6 cycles of chemo. We've had some patients say they just want to get it all done at the front. Problem with that is you have to be careful. You don't want to hurt the liver with the chemotherapy. But the sweet spot, most people would say, is 4 to 6, cycles.
And then this other group where you said there's a targetable mutation or genetic, that means that you're using something that is more specific than chemotherapy, or that means that there are certain surgical approaches? I wasn't.
Yeah. So the surgery is the same.
Okay.
What we've learned, and this is like a huge, exciting time to be in pancreatic cancer treatment and research, is for decades, like more than decades, we haven't had a immunological approach which worked, a next gen sequence approach which worked for pancreas cancer. But we're getting there now and understanding the genetics and then targets for some patients. And we think it's probably up to 40 or 50% that have targetable mutations that we can give either in the adjuvant setting or in the neoadjuvant setting. And we're getting, I mean, this is super hot and very exciting because this is something that other areas of oncology have really taken off with for a while. And finally, just in the last few years, we've got this space to really push it with offering upfront and even adjuvant therapies, which aren't the standard, very toxic, debilitating therapies.
So that's the kind of stuff that puts a surgeon out of business, isn't it?
Absolutely. I would be the happiest surgeon on the planet. I love to operate, but I would be the happiest surgeon on the planet if these just started to walk. If you could treat it like, like some of these lymphomas and some colorectal liver mets where it just kind of dissolve away.
Yeah. So let's talk about the screenings. You've got the clinic that's in development. You've got a method for screening people and trying to do some support research that's on this early detection end. What do you do when you find something that is suspicious? How are the options changed when you find something very early?
Yeah. So first of all, the prognosis for finding an early cancer is dramatically better than obviously a more advanced cancer. But to answer your question, like, what do you do when you've got, let's just say, a BRCA patient who's feeling great? They've had their their GYN surgeries, they've had their breast surgeries, and they get told to come to this clinic, and we scan them, and we get either an MRI or an endoscopic ultrasound. Probably would start with an MRI, and it shows a hypodense mass, possible cyst that just doesn't look right.
Mm-hmm.
The first thing we would do is we would enroll a patient in the screening trial where we collect their blood. We'd also send a CA19-9 level, which is not a great test for pancreatic cancer, but it's all we got.
Sure.
And if the CA19-9 level is elevated, let's just say over 100, normal is less than 35, and the cyst is suspicious, I would definitely recommend getting a biopsy of this cyst, confirm the diagnosis that it's not something that's benign, but have a very serious discussion with the patient about whether we need to remove that cyst, which is usually a big surgery, or watch them very closely.
For somebody that, let's say, they've got high family risk, suspicious for genetic risk, they've done the screening, they don't have anything, but they have diabetes, they've got some regular alcohol, they've got some obesity that's there. What types of support resources are engaged to try to help reverse some of those types of risk factors? And if they're successful in reducing body weight, reducing the blood sugar piece, like how does that confer a reduced overall risk?
Yeah. So I can't say this strongly enough that smoking is the number one risk factor for developing pancreatic cancer. If someone comes in my clinic for screening, if they're a family member, our team will tell you, I'm getting on them. I mean, I'm not going to be your friend to work through stopping smoking. I'm going to tell you to stop smoking.
Thank you for listening to Living Real Change. To hear more stories from across Piedmont Healthcare, be sure to subscribe and watch for upcoming episodes. For additional health tips, news, and resources, visit us at piedmont.org/living-real-change.